We have the world at our fingertips, inspiration in our touch, and power in our hands. Our hands, gentle enough to hold the next generation, yet strong enough to build movements that can change the world. Our hands can build relationships, frame ideas, and empower communities. We have the ability to share and imagine, create and comfort, love and heal the world around
Love
us.
this video.
And it doesn't stop there. Right here, in our hands, we have the power to save a life. If you see a teen or adult suddenly collapse, call 911 and push hard and fast in the center of the chest.
The power is in your hands.
Good evening and welcome. My name is Pamela Garman Johnson. I serve as the National Vice President of Health Equity and Partnerships for the American Heart Association. And we are so delighted to have each of you join with us this evening to have a discussion on an important topic. We began this series of roundtable events last month with the aim of shedding light on topics critical to the health and well-being of women of color. In February, we had the opportunity to convene the leaders of the Divine Nine sororities and the Links Incorporated to share their journeys navigating the COVID-19 pandemic and the impact that it had on Black women. This month, we delve into the ways in which opioid misuse is affecting Black and Brown communities, and why women and people of color experience health inequities because of lack of training in CPR, a life-saving skill that can improve cardiac arrest survival rates following a heart incident, including incidents due to opioid misuse. Our CEO, Nancy Brown, is here to welcome each of you and to share an update about the American Heart Association's recent advisory about opioids and heart health. Nancy.
Good evening. I'm Nancy Brown, Chief Executive Officer of the American Heart Association. I am honored to welcome you and all leaders and advocates who have been on the front lines helping women and people of color overcome opioid addiction and its causes. We know that structural racism is a major cause of poor health and premature death. Black, Latinx, Indigenous, and other people of color also experience a disproportionate amount of stress related to health outcomes. When you add the COVID-19 pandemic into these existing challenges, it is no wonder we are seeing an uptick in opioid use and addiction. As a champion of health equity for all people, the American Heart Association is more determined than ever to leverage our voice, our platform, and our resources to identify and remove barriers that prevent people from living long and healthy lives. The Empowered to Serve community impact teams are working with faith-based organizations to end opioid use in collaboration with American Academy of Addiction, Psychiatry, and Opioid Response Network. Tonight, you will hear more about this pilot program and the opioid education courses that will help people recognize and respond to a possible opioid overdose. This is particularly valuable for people experiencing cardiac arrests, as people willing to perform bystander CPR during the pandemic has decreased. We look forward to hearing from you on how we can improve the overall health and well-being for communities that need us now more than ever. Thank you so much for joining us.
Well, thank you so much, Nancy, for those words of encouragement. Tonight, we have convened a powerful group of voices to share their expert advice and personal stories. It is now an honor to introduce our moderator for the next hour of conversation along with our panel. Lydia T. Blanco is a trusted journalist, vibrant host, and digital media personality who is passionate about building community through storytelling. I love storytelling. As a media professional, Lydia is committed to amplifying the voices of people in marginalized communities and humanizing the experiences of those who are often overlooked. Lydia, thank you for leading this discussion. Next, Paula Blackwell is the Executive Director of Central Maryland Area Health Education Center. Ms. Blackwell has more than 25 years experience developing and leading health and human service programs throughout the Mid-Atlantic region. Thank you, Paula. Minister and licensed chemical dependency counselor Brandon Holt also joins us this evening. Mr. Holt shared his personal story of opioid addiction and recovery in his best-selling memoir, Preaching Under the Influence. Thank you so much, Brandon. Next, Katherine Cates-Wessel is the CEO of the American Academy of Addiction Psychiatry, which is AAAP. Ms. Cates-Wessel has more than 30 years of background and experience in substance use disorder field in administration, medical education, and policy. She is principal investigator and project director of several federally funded grants, including Providers Clinical Support System, Opioid Response Network, the Minority Fellowship Grant, recognizing and eliminating disparities in addiction through culturally informed healthcare. I love that. Or REACH, an expansion of interprofessional educational. Thank you so much, Katherine. And then lastly, Abagail Kohler is the co-founder of Resuscitech and the 2020 AHA Empowered to Serve Business Accelerator top finalist. So proud of you, Abagail. Her company's app, Smart Certification, provides people with convenient smartphone-based training that provides hands-only CPR compression practice with real-time feedback. On behalf of the American Heart Association, I welcome each of you. And now I will turn the program over to Lydia, who is the moderator for this evening. Lydia.
It's an honor to be a part of this conversation, Pamela. This is an outstanding panel to bring both the physical and mental health issues related to opioid misuse and solutions to light. So let's get started. After watching the news, many of us have the impression that opioid addiction is not a problem in Black and Brown communities. How has this affected the way that people of color are treated as it relates to opioid misuse and overdose? Paula and Katherine, I'd like to start with your thoughts.
Paula, you're on mute.
Sorry. Thank you, Lydia. It is a misconception that opioid use is not a problem in Black and Brown communities. Nothing has changed, just the terminology and the biases the community at large has about the types of opioids that are misused and who is misusing. There is a social distinction between prescription opioids and street level opioids such as heroin. Same substance, same disease, different perceptions about the substance and the substance user. In metropolitan areas, the community focus on opioid misuse is often on heroin and fentanyl. There is not much community education about prescription opioid misuse and dangers. This lack of information has led to an increase in opioid misuse in Black and Brown communities, among women of all ages, and older adults, especially those living alone. The need is great across all demographics. However, funding is not always equitably allocated across rural and metropolitan areas. That is, funding is not allocated based on population density and the prevalence of addiction and death. There's a fierce competition in metropolitan areas for funding to educate, prevent, and treat opioid abuse, especially during COVID-19. Because of limited funding, healthcare organizations and agencies are often not able to effectively address the social determinants that may exist as barriers to prevention information and to treatment, and for social supports important for sustaining recovery. Katherine, your thoughts?
Paul, I mean, I totally agree with you. I think you bring up some really important points. And I think the first thing is someone like myself, a white privileged woman, to be able to stand up and take this as an opportunity to take responsibility. We have to learn to have these discussions openly and honestly. I was raised in the South. I have a son who is from Ethiopia. So I'm learning every day, things that I need to know and to be better educated on how to address things. I think also that just clarifying certain things like the difference between Black and brown and what that means, because being from the indigenous community, we've seen that they and all parts of substance use disorder and opioid use disorder have had the highest level of overdose. And then through COVID, we've seen a decrease in the early points of COVID, somewhat of a decrease in opioid overdose in the earliest parts, and then an increase for those for the Black community. So I think getting that awareness out and distinction to clarify why there's so many disparities in so many areas. And I'm so thankful that each of you have commented about mental health, because that's the elephant in the room, if you will, because quite often people don't talk about them coming together as being co-occurring, and more often than not they are. And again, that's another health disparity that the Black and African communities of color have once again been left out of getting the attention. I think the other thing is educating health professionals, and that's a big part what my organization is really charged with doing in a variety of ways, is educating health professionals about how to be culturally aware and educated and trained. There's certain things that we need to understand how to approach someone, what things that are important, and how to keep that in mind before approaching someone about their substance use disorder or other issues. So there are lots of opportunities. Again, I have a lot to learn myself. I hope to walk the walk. It's not just talking about it, but do it. And I just want to give a couple examples of some of the things that we at my academy are doing. One was the REACH grant, where we're actually paying for underrepresented minorities to get their fellowship to become an addiction specialist, not only so they can treat, but so they can be leaders in the healthcare community to help educate others about things they should be doing to meet the needs of their community, but also to serve as role models. If people in the community can have people that look like them providing the care, they feel more likely to come back. And we know engaging the patient is a really critical area, and particularly when it comes to things like substance use disorder and co-occurring mental disorders. Another grant we have, like what we're doing here with the American Heart Association, is called the Opioid Response Network. And anyone in any state, any territory in the country can put in a request for training and education, and at no cost get free training and education on substance use disorder, but opioids and stimulants. And specifically, we have a work group highlighting Black African-American issues. Their charge is to tell us what type of training materials do we need, how can we be culturally aware and educated, and then to vet consultants to make sure that we have the right people out there. So those are just a couple of examples of things that we're trying to do as an organization to walk the walk and to get out there and to be on the platform and to speak out to make real change.
Very insightful learnings. Thank you so much. Brandon, as a survivor, can you share with us a little bit about your personal journey and how the use of opioids impacted not only your life, but the lives of the women who are ever present in your life? And secondly, do you feel as if you were treated differently as a Black man?
Good evening, everyone. To answer your question, grew up in Arlington, Texas. My father's Black, mother's white, biracial, struggled with approval addiction, coming up, validation, acceptance. Entered into the ministry at a young age when I was 23 years old, 22. I got in a car accident in the Los Angeles, California area as a pastor. I was a full-time pastor, and I had a 5-hour back surgery. I never experienced any type of drug use. And when I had the surgery, they prescribed opioids to me. And at the time, I didn't know what a painkiller was. And so as I started taking the medication, it was helping me physically. But after a while, I had a psychological dependence on it, experiencing the withdrawals and so forth. I ended up losing my family at that time. I was a pastor, so I was up, preaching and teaching, but I was, dealing with this addiction at the same time. I was doctor shopping. I got, then I got red flagged. I was taking the medication to function because I needed that. I would go up in the pulpit and I would actually have a white cup of cough syrup, codeine syrup, and I was taking that in order to level myself out. So it was a very dark place. I didn't know a lot about drugs and alcohol at that time. And so I tried to stop, body kept kicking, couldn't stop. And when you think you're looking good, you're looking bad. So at that time, I wasn't aware of how I was looking because I was trying, as a young Black professional, I had a family. I didn't want to lose everything. So I tried to hide it and cover it the best way I could, when in all actuality, I was falling apart in front of people. So to fast forward to where we are, I tried to quit several times and I kept relapsing on the medication. Back pain was gone. I used an old tooth injury to justify prescription when I would go to the doctor, or I'd come up with some type of injury. And then one day I decided I'm going to quit. And then I stopped cold turkey. Big mistake. Didn't know I was supposed to actually taper down. Got on Suboxone. Suboxone actually made my situation worse. And then finally, when I did end up quitting, I ended up going to school to get my license in chemical dependency counseling. And I've been a chemical dependency counselor now for 10 or 11 years. And so I'm working in a treatment center now in Houston, Texas. That's a 1-year residential men's program where we actually, are right down on the front lines. Now, to answer your question, as a person of color, how did that impact me? I really don't know at that time because it was so long ago and my mind was not really clear. But as I look back over it today, I've learned that a substance use disorder is no respecter of persons, no matter what your ethnicity is. It just so happens that, the opioid use disorder is kind of classified differently as opposed to the crack cocaine that happened years ago, and that affected the African-American communities, which you saw masses of incarceration. And so I'm very grateful today to be sober. I've been sober for 14 years now, and I'm here to just help as many people as I can. Very grateful to all the panelists. Really enjoyed listening to what you had to say. And I think the key is transparency. I believe that everybody is struggling with some type of addiction, whether it's substance use disorders, sex addiction, gambling, whatever. And as professionals, sometimes we try to cover it up. But I think the key to healing is being transparent and saying, hey, this is what I'm struggling with, and this is how I got through.
Brandon, that is incredible. Thank you so much for sharing.
That was the quick answer.
I appreciate that answer, and I celebrate and honor those 14 years. So thank you for your ministry.
Thank you.
And your work.
Thank you.
You are welcome. Abagail, is there anything that you'd like to add?
Yeah, I would just like to add that these disparities and biases, unfortunately, impact how often CPR is attempted on people of color when they need it, which ultimately leads to higher mortality amongst people of color, including those who experience a cardiac arrest as the result of an opioid overdose. So ultimately, I hope this is something that accessible CPR training solutions will play a part in addressing, because it'll give more people the education necessary to attempt CPR in these situations.
Definitely. And Katherine and Paula, are there any final thoughts that you'd like to share?
Paula, would you like to go?
Hey, Paula, you're on mute, ma'am.
I was just going to say that, Brandon, for sure, prescription drug misuse is the silent disease. It's the silent killer, and it's not often self-reported. It's not often recognized by primary care and other health professionals. And so in Black and Brown communities, it's often untreated. Central Maryland AHAC recently partnered with the American Heart Association to educate faith-based organizations located in areas with high overdose death rates. We educated them about opioid response strategies, including CPR as a intervention. And the response from the church leaders was very positive. And the congregation seemed to really appreciate the information. During the training, one participant did reveal how helpless and ill-equipped she felt when she discovered her elderly aunt unconscious from what she described as an accidental overdose. And the church leaders have recognized the importance of training their members in the community at large to intervene to increase knowledge about CPR as a response to opioid overdose.
I think building on what Brandon and Paula both said, I think it's really important across the board, because for so long there's been an anonymity aspect of this where there was so much shame and denial, and that was part of the history of this field. And I think it's become so prevalent. It's always been there, but it's taken certain situations for it to raise awareness around it. For whatever reason, we have to think of this as a positive change, in that now people are openly and honestly talking about it. There are no boundaries. It's not because of education. It's not race. It's not where you live. It's everybody, and it can touch anyone. So I think not only educating the general public so they can question things, but also health professionals were not trained on adequately how to treat pain. And so that's part of what the problem was. The other piece of it was health professionals have not been trained how to screen people that are at risk for substance use problems. So someone like Brandon, who had not had an issue before and got addicted because of inappropriate prescribing or whatever, he might have been prone to it or have been susceptible to it, could have been avoided early on. So there are a lot of just lack of knowledge and information. Using the church is an excellent way. I grew up in the South. You'd go and talk to your minister before you talk to your primary care provider. Or other people will talk about the legal aspects. That's another thing that we're working strongly on. You have to get the judges educated. You have to get probation and parole, because particularly for the communities of color, that's where so many people are warehoused because of inappropriate policies that target low income and minority communities. So it is a multifaceted, comprehensive, problem that we all have to talk about openly and honestly. And I think bringing communities of color, people of color to the narrative, have them talk about it, but also have individuals that you might not think about as having the typical, they say the typical person that has a substance use problem, a minister. You're not going to say, oh, they would never, or a bank president, or highly educated, or stewards in the community. Those people, judges, people have problems, and they all are impacted by it. So I think having them in there, having things to raise awareness, telling the stories, that's how you make change. And I think that's the kind of thing that collectively together we can all make a difference. And it's having people from every walk of life and every perspective to say, this is a primary care medical disorder that has co-occurring, mental disorder issues, and it impacts us in a variety of ways. And how can we come together to meet those specific needs? And each person is uniquely different, whether their culture background, their education, but they're individuals. And I think we have to be more sensitive to that when we start treating people.
Well said, Katherine. That's why this conversation is so important, right? The American Heart Association offers CPR training all around the country and the world. But as much as it's available, there are still disparities in training and in use in communities of color. I'd love to know, why is it important to learn the skill, and what difference can CPR make when someone is experiencing an overdose? Paula, let's start with you.
I'll just mention that because of the disparities in the training, typically the training has not been available in communities of color. Often people in the community think there's a cost with the training. However, now we're finding that the training is free. Right now, the disparity is the digital divide. Training is free and available online. And many communities, many people in the community do not have access to internet, do not have access to a smartphone or device where they can access this free training. And such, our churches that we've been working with in Central Maryland are very interested, once it's safe to do so, in providing actual hands-on in-person training, because they're recognizing that it is important to prevent preventable deaths.
That's really good information. Thank you so much, Paula. CPR can literally save lives, especially someone who is experiencing an opioid overdose. Abagail, this is your area of expertise. What can you share about the work that you are doing to make sure that CPR is a skill that is equitable and available for all people?
Yeah, so I'm the CEO of Resuscitech, and we've created a mobile app that enables people to learn CPR and get certified from anywhere. So despite the fact that there is a digital divide, we hope that most people can find 90 minutes at some point in their lives with access to a smartphone, because that's all you need with our program to learn CPR. And if you're one of the many Americans who owns a smartphone, then you essentially have a CPR trainer right in your pocket with our app. So our app is called Smart Certification. It's available on the Google Play and the Apple app stores. And downloading the app is completely free, and all of the learning on the app is completely free. So we've addressed that barrier of cost. The app also contains gamified learning modules, really quick videos, and finally, the hands-on chest compression practice and evaluation session to make sure that we keep people fully engaged with the app. And the videos are really helpful to make it more accessible for people who maybe struggle to read long blocks of information for a long period of time. We really wanted to make sure that people stay engaged with the information, which is another part of the reason why we made it gamified, to ensure that people are really sticking with it and feeling a sense of reward and accomplishment. You actually earn points as you go through our app, so I think that helps people feel like they're engaged with the information. And then as for the hands-on chest compression practice and evaluation part of our app, people really, all they have to do is hold their smartphone like this while practicing chest compressions on a household object, like a cushion or even a mattress or pillow, but a couch cushion works best. And then the app gives you feedback to guide your compressions and ensure that your chest compressions are accurate, so that you build your confidence and you know how to administer chest compressions correctly. So our training is designed to be done entirely remotely, because we know that many people don't have the money to attend expensive in-person classes, or even if they're free, they might not have the time or opportunity to attend because of other obligations or other things going on in their life. And we don't think that should bar people from life-saving information. Not having time or money shouldn't be the thing that stands between you and the capacity to save someone else's life. So we really want to deliver that to people. So this increases accessibility and makes CPR training available to more people. It makes it available to anyone who has access to a smartphone. So rather than force people to change their ways and adhere to the ways a lot of CPR classes are offered, we created CPR training that meets a lot of people where they already are on their phones.
That is incredible. Resuscitech is synonymous to access, which is to be appreciated. You know, we also know that there are gaps as it relates to women, right? Can you share any insight of the importance of understanding that women, despite their anatomy, can receive and need to receive CPR when in cardiac duress?
Yeah, of course. So women and people who have breasts receive CPR less often when they experience a cardiac arrest. People are uncomfortable administering CPR to someone with breast, despite the fact that they need it just as much. It is just as necessary and just as important. So one of the things we know is that representation matters. So when you practice CPR on a mannequin, you're often practicing CPR on a mannequin that has an anatomy that's very male, and often that CPR mannequin is white. So people aren't seeing themselves represented in these simulations and in the CPR training that they attend. So that is one of the things that our training is trying to tackle. We're trying to address these disparities and ensure that we represent all people who might need to receive CPR, which is quite literally all people. So we've made sure to include diverse bodies in our app so that people know and have a sense of what it might look like to perform CPR on anyone.
That's incredible, Abigail. That is a real inclusion, and that matters. So thank you for your work. Katherine, I would love to hear your insights.
So I think, again, being accessible to a variety of training and educational opportunities at no cost is really critical. Just getting people really going out and learning more and understanding that a lot of things that haven't been talked about before are out there, and we need to do it. I urge everyone to go to opioidresponsenetwork.org. If you put in a request, anybody, anywhere can receive free training and education at no cost to you. And within one business day, someone in your state will follow up, a technology specialist, and identify prevention, treatment, or recovery consultants to come and meet your needs specifically. So I encourage you, if it's in the church, you want to have somebody come in and give a talk about stigma, or you want to talk about, explain what is how do medications work, and why is it not exchanging one drug for another drug? Explain to me what happens in the brain. And that's a very typical thing that people don't understand. Well, I'm not going to go on a medication because I'm just going to be switching from one addiction to another, but try to explain the science. Or just talking about working with the recovery community. There's a variety of things that can happen. So I urge people to make use of that. That's your tax dollars at work. This is free, free, free. So put in a request, have somebody come in, and they can do it on your terms. You say what you need and your target audience, and it's at no cost to you. So I'm just hoping that people will take advantage of things like that and letting us know what your needs are. If it's something that we don't have, it's our responsibility to get you what you need in the way of education and training. So talking about it openly and honestly, and saying these are the expectations and needs. And I think the more we can do that and be, as Brandon said, transparent, and to be open and to not feel the shame that has been for so long, and thinking about the legal aspects of it. This is a real public health and a public safety concern. I just am very thankful. I've been in this field a long time. There's so much stigma within the medical community. People in the medical profession don't want to deal with people that have mental health problems or psychiatric disorders, or people that have substance use problems. So I'm a double whammy. I've got my group is mental health and co-occurring substance use disorders. So the medical community doesn't particularly like to work with addiction psychiatrists because you work with those people. And I think it's time we shed that and we get rid of it and say these are health problems that everybody is, except are prone to, some more so than others, and it happens. People don't choose to be in that position. But what can we do to provide evidence-based and supportive care? So I think the more that we can be real, like Brandon talked about, I think the more likely we're going to be able to see real change. So I truly believe together we will make a difference, but it's going to take being, honest about it.
That's really good. And Katherine, thank you for highlighting that we should advocate for, self-awareness, awareness, and just education on our terms. You said our tax dollars are used. Very powerful. Thank you for highlighting that. Brandon, I'd love to know more about your insights, especially leading as a person of faith with this experience and some of the things that you are incorporating in your ministry, in your congregation, and just in your everyday walk and profession.
Wow, coming behind all of this. Well, that's a great question. I think that, Lydia, the definition of success is when you finally realize that it's no longer about you. Life is short. We're only here for a few minutes. And the key is, am I making an impact every day? All lives, everybody matters. And the key, like I stated earlier, is people want to see realness. They want to see transparency. They want to see people that they can relate to. They want to see, someone who's not afraid to tell their truth and tell their story. As far as the ministry is concerned, we have a couple other chemical dependency counselors on our team, and that's just a separate entity where, we make ourselves available for any type of counseling and so forth that they may need. But I just think, like I said earlier, the key is when I can finally get to a place. It took me a long time. Like, I really hid my addiction for a long time, and I wasn't aware that my behavior was impacting so many people in a negative way until I look back. And you asked earlier about the women in my life, how that impacted them. I really can't even answer that because we're talking about 14 years ago. I have no idea who I was at that time. So I just think that if we continue to educate, CD education, like ladies beautifully stated, we just have to keep educating, making training, available for all, whether it's CPR, substance abuse training, mental health training, etc. And I think we can start making some ground.
Thank you for that. And Paula, I would love for you to share how we can create more equitable circumstances and resources, especially in Black and Brown communities and for women.
Thank you, Lydia. Well, in honor of Women's Month, I just like to recognize women as the carriers of the burden, as the gatekeepers for wellness and well-being for our families, for our communities. I think when we can identify and effectively address the mental and physical and the social needs of minority women, that we can begin to improve the health and well-being of our communities, not just for now, but for generations to come. I think the tools and the information that we can provide to women go a very long way. Learning about CPR, learning about naloxone, learning about self-care, and supporting women in the work that they do in their communities, in their homes, as well as in the workplace, goes a very long way in addressing many of the social, physical, and mental issues that we are encountering now as a society.
Absolutely. Well said. Well said. Thank you all for being so transparent and willing to share your stories. We know that conversations about opioid use are difficult to have, especially as it relates to Black and Brown communities, but it is an important one. As influencers, you using your voice is making room for others to use theirs. So thank you. As our time comes to an end, please know that you can find additional resources at heart.org. The American Heart Association also has additional resources in a collaborative program called EmPOWERED to End Opioid Use, and you can learn more at empoweredtoserve.org. And for information specific to women in heart health, please visit goredforwomen.org. This was such an important and timely conversation. Please, if you are not already, get trained in CPR. Pamela, I'll turn it back to you to close us out.
Wow, it's such a powerful discussion. And Lydia, thank you so much for sharing your voice and your influence as our moderator tonight, and to our speakers. Wow, and thank you, thank you, thank you, because your transparency, your vulnerability, right, of sharing your journey and your willingness to learn more about this topic so that you could be and are an influencer in this area is so important. As I listened to the discussion tonight, there were several things that I just want to reinforce. One, we can all be trained in CPR. That's one thing. Two, if you are dealing with an issue, please seek help. There is someone that you can speak to. And I think that no one is, I guess, absolved from being impacted from mental health challenges. And then also knowing that you have, you can use your voice to help others. And if you recognize others that are being challenged in a specific area, you know, reach out, ask questions. I think that each of us has the power. The power is in our own individual hands. And then also the power is within our respective communities. And so to watch this collaboration among all these different, very different partners come together tonight really shows that it is through collaboration and partnerships and strategic relationships and just the ability to listen to others, we can make a difference. And so what I would like to do is extend an invitation as we will continue these roundtables so that we can inform others and you can hear from thought leaders across the country during the month of April. April is Minority Health Month. And so on April the 20th, the American Heart Association will focus on breaking down the barriers affecting the mental health of women of color. And so if you will go to empoweredtoserve.org, you can learn more. And so with that, we will conclude this evening's discussion. And we appreciate each of our panelists tonight and lending your voice and expertise and your experience. Have a good evening and take care.